5 questions for each of the speakers, but Joe, let me start with you. TEER, we're all going to be seeing more failed TEER, just like we're seeing failed TAVR valves. Do you always try this hard with this? I mean, oftentimes they're high-risk patients, although I think that last patient you saw was 38 years old, so there must be a story there. 45 minutes of trying to remove the clip in a high-risk patient that's maybe early 80s or something, and basically how far do you go with that?
Yeah, very sensible question. Speaking to the last patient, who was a young patient, essentially presented in cardiogenic shock, ended up on ECMO with shock liver, obviously dialysis. So the clips were done as a salvage, actually got the patient down to MR, weaned him off ECMO, got his liver function working again, sent him home, and he came back 3 months later to have a proper mitral valve repair. And I think that in an older patient, most of them, if they're surgical candidates, it's worth the effort to try and repair. Chopping those valves out and putting in a valve replacement is a very reasonable thing to do in many of them. But I think as we see more aggressive use of clips, it does behoove us to know how to re-repair those valves. We've spent a lot of time talking about surgical mitral valve re-repair. Let's all learn how to re-repair TEER.
But it's important to note in the big picture that 95% of the patients have a valve replacement if
Correct.
they've already had TEER. So.
And I would say that in our practice, we can re-repair about 90% of the degenerative patients. If they had TEER for functional or ischemic, they're not re-repairable. Those are just straight. There's not enough tissue. Just replace those.
We'd encourage you, please, to ask questions here. We have 15 or 20 minutes. One more follow-up question that's unusual. A 38-year-old comes in with cardiogenic shock. What was that? It was a sudden ruptured chordae? Because usually...
Oh, no. It certainly wasn't sudden ruptured chordae, but I mean, I think great question, but no, there was a huge bileaflet valve.
Yeah, strange.
Obviously watched long time, not maybe treated.
Okay. I had a question for Rachel. Rachel, that was a great video that you showed. This is an operation that we don't do very often, but very doable, but you have to have some tips and tricks, which you showed beautifully. 2 questions. How often do you have to do something to a aberrant papillary muscle? And the second question is this operation going to be gone in 10 years because of, what is the name of the medication now?
Yeah, no, it's definitely...
Mavacamten, thank you.
So definitely there you can see that there is a drop in the amount of myectomies that need to be done due to some of the therapeutics that are out there. I think if you have isolated SAM with that late posterior directed mitral regurgitation, a lot of the times you don't have to do anything to any papillaries, and only if you start to see a jet that looks a little bit more suspicious or having more central that you start to look at the papillaries. So not very often from our experience at least.
Great. Gabe, you described sort of an economical resection for the active endocarditis, or maybe kind of a conservative resection. I was always taught to be aggressive and to remove all of this infection. I was watching your video. I wouldn't have called those conservative. So I think actually it's the same thing, is that, we called it aggressive, you called it conservative, but the point is to get to like healthy tissue, correct? So whatever it takes to get to that. How do you know it's healthy tissue?
I mean, if it is not healthy tissue, let's think this way, it means that there is some perforation or rupture or free rupture. So I think over any infected tissue, we should have some healthy tissue. It's impossible not to have a healthy tissue. If not, patient is dead. Mm-hmm. So the things is, I mean, we mainly on the posterior with MAC, all the things. I think it's always possible. Do you have some kind of, let's say, fibrotic reaction to the MAC, and really staying in this plane, we found that it's always possible, whatever is the infection or whatever, really at the right place.
Is it right to think of it as just something that is going to be significant, that's going to be able to hold sutures, just something that is, they're not infected and is going to be enough to support your replacement or what?
Now, in some patients, when the infection is really, let's say, goes into quite deeply into the left ventricle, we don't hesitate to cover with pericardial patch. Yeah.
But Gebrine, I'm glad Tyrone stood up, because I was going to ask him. Tyrone, you said in your talk that you've tried lots of different patches on extending to the free edges of leaflets, and you've been disappointed with the long-term results. But Gebrine is telling us something very differently for his mitral valve repair for endocarditis.
Well, our experience is different. I think if you put a patch, particularly an anterior leaflet, they'll come back. 5 to 10 years, the patch become calcified and either restricted or recurrent MR. So I don't, the only patch I have not used, and one of my former fellows using in South Africa, is saphenous veins. I don't know if anybody has experience here. No. It takes a short segment of the saphenous vein for the groin, open longitudinal, sew to each other, and they have a patch of 3 or 4 centimeters by 5 or 6. I never use that.
I will use it next year, next week. I will use it.
Have you? I have used a core matrix, which I jump in the bandwagon with my, I'm begging for a patch, and half of the cases failed within 5 years. Autologous pericardial remain the best one yet, I think.
But as we know that pericardial will fail in some years, but at least in this, at that time, the the endocarditis process is cured, and you can replace or whatever later on or whatever. So don't you think that it is always much better than put a biological or mechanical?
Well, I don't know, Gebrine, for endocarditis. Your own series, and everyone I have a review for the journal, for Joanna and for the Journal of Thoracic and Cardiovascular. I didn't review your paper before it was published, but I would have asked the authors, why is the operative mortality 4 times higher for replacement than repair? Is mitral valve replacement a bad operation that kills 4 times more people? My answer is no. The patient who, a surgeon like you, had to replace the mitral valve was much more extensive damage. They were sicker, they were in shock, they were in renal failure, they had 2 strokes. That's why mortality was 30%. Exactly. Repair, they are healthier, they came in the operating room talking to you. Well, those, of course, I can get them through the 6 months with a 10% mortality. So I think the higher mortality for replacement is not the replacement. In endocarditis I'm talking about. I think it's the clinical profile of the patient when they come to the operating room. Your graph showed how different in mortality was in the first year. Then it plateaus up to 7 years. So in most studies that compared replacement with repair in infection endocarditis showed the same thing. Is higher perioperative mortality. And Mike, you must have hundreds of patients.
In the endocarditis guidelines, which we published 2 years ago, unfortunately, it's not very well known in the surgical community because it's a cardiology journal. It's the European Heart Journal. But I would really recommend everybody to read that document because it is very pro-surgery. We had a lot of surgeons on the task force, and we made sure we stressed that surgery is the only curative technique for about a half of patients with endocarditis. And the data is difficult to interpret exactly what you said, because of selection bias, and therefore we never came out with any strong recommendation for repair, except for the tricuspid valve patients, the drug abuse patients, because they come back in 6 months with an infected prosthetic valve if you replace the valve.
But I agree, and perhaps that's I don't know about in Europe and elsewhere in the world, but in Canada, in the United States, the number of patients coming in IV drug use endocarditis is skyrocketing. Perhaps in those we should try as much as possible to repair and not put a prosthetic valve inside.
David, is it the same topic? Endocarditis?
No, I'm standing up there to correct something, because I got 2 times now we've said the Carpentier used intertrigonal distance to measure a ring. This is incorrect. In the book, we show it very clearly. You look at the rough zone, you place a ring, you have a surface area of the sizer, and you want to see the rough zone of the anterior leaf foot below it. That's about 2 millimeters. That's the primary method of sizing a ring, if you want to use sizers. And every other company and every other product was copied off of that original idea. The 2 indentations, which I have tried to get Edwards to remove, but they won't because it costs money, because I find it very annoying through small holes. You have all your sutures in, you're trying to put a sizer in, and it grabs all the sutures. I keep trying to tell him it was historic. He used to put a suture at 7 o'clock and 2 commissural sutures and did the repair. Then he sized the ring, then he put the rest of the annuloplasty sutures in. I see Michelle nodding. He used the 2 sutures in the corner inside the 2 little V to push the ring down and put it, so he locked it in the anterior leaflet and then pulled the leaflet down to measure. So it's not true that we're measuring intertrigonal distance. You could consider that, I guess, a secondary measurement because the line's there and the V's are there, but that was never the intent of it. It was always the surface area. The other comment I wanted to make was about, Joe, the video you showed where you did multiple, with the calcium and the commissure. Yeah, I really liked that because I liked it because of the way it reminds me to tell people, there are no grand slams. You actually did 3 operations within that one operation. You addressed the posterior leaflet, the posterior commissure, and the anterior leaflet segmentally. And that really is the best demonstration of anything we saw today of what a segmental approach is. You have to fix, many times in complex valves, you have to fix it sort of a quarter at a time. There is no magic to like fixing the whole thing with one maneuver. So you guys should remember that idea when you get to the complex valve, calcified commissure, bileaflet prolapse, the extension of the anterior leaflet, that's where you use a triangle to try and create the oval again. But I thought that video really showed that well.
David, before you
Thank
sit
you.
down, I want to follow up on that point. I want to ask Ahmed about the severe MAC. Tyrone showed a great video today where he takes out this huge bar, also Gebrine. But if the bar extends up into the medial fibrous trigone, my personal experience is that's difficult to deal with. You can't put a patch up. You know, you're doing like this, trying to sew your patch up into the LVOT. So if that's present, is that where you right away go with the sapien approach?
I guess it's even more complicated if the anterior commissure is involved because I think for the posterior trigone, you can always go around the MAC, or even sometimes you go on the right atrium and put the suture from the coronary sinus. The anterior trigone or the anterior commissure is the most dangerous part. That's in our experience in trying to get around it or to take it out. Because you're right, you can run out of tissue at that corner, and then it's a bigger problem.
I loved your video though, where you were showing the big needles going down to the intact epicardium. Because if the epicardium is torn, what you're sewing to, your suture won't hold. And then you over-sewed it with a stitch, with a pleated suture as well, which I also think is really important. Oftentimes we use the LVAD sutures because they're so big with the big felt pledget like was in that video.
Yeah, I think Dr. Adams, if you can comment on that.
Or just, what we're trying to do is...
Tyrone, do you have any tricks? Do you do these contortions that we just saw here? I can't picture that.
But 2 things I'll say, it's about to finish that comment before Tyrone comments. If you're in the anterior commissural area and you can get there with tumors primarily, if you take out that hinge point in the anterior commissure, you're looking at the aortic cusp. If you have a short aortic fibral curtain, you're now going to be sewing your patch into the hinge point of the aortic leaflet. That happened to us recently with a tumor in that corner. So it is a very narrow space in many people. So once we see that, then we tend to go to hybrid approaches. What I will say about those big needles is I learned historically in my training to sort of take the big, if you can't get around the calcium, keep taking a bigger needle till you get around the calcium. And that's how you get AV disruption. I think you've got it, because then the rings really won't, you really got to be, I think that's where we came up with that whole thought process of respect was from tragedy. And that's how we ended up thinking about different size needles, sometimes left atrial sliding plasty, occasionally a patch, not very commonly, but occasionally a patch, usually limited resection, sliding atrioplasty. But the big needle really does help you if you're going to try and do an anterior leaf foot flip and then sew the valve in front of the annulus. As Ahmed showed, basically implant a valve replacement in front of the annulus, not behind the calcium.
So the calcified medial fiber trigon, extensive calcification there. This patient almost invariably are older and the aortic valve is not normal. And to be quite honest, the aortic valve has moderate disease that you can live with it. I chop the aortic valve out. The whole operation done through the aortic root. I find to remove a calcium bar and reconstruct the posterior mitral annulus through the aortic root is immensely easier done through the right thoracotomy or sternotomy to the interatrial groove. Because remember, after remove the block of calcium, be for radiotherapy, for the stroke of the elderly patient, or the myxomatous mitral valve, if the aortic valve is out of the way and you split the intervalvus trigon, that hole is pretty big. You're looking like 2 or 3 centimeters below the level of the heart where the patch has to go. In those, we learned, when the calcium goes down to papillary muscle, and I have to sew into trabeculated area, it becomes a problem. So we initially interrupt more often, 2 or 3 bites interrupt, 2 or 3 bites interrupted. Last week, for the first time, I went outside the heart because I know it's going to fall apart. So I took a strip of Teflon, look where the coronary arteries were, brought the suture inside. She went home yesterday. 83-year-old, because I knew if I suture in the endocardium, and Malak, one of my residents, we are looking to this now. Of the 300 and some MAC we have done, a third of them, the aortic valve had to go and was done to the aortic root. So the struggle that you're describing is real, Michael, but I'll bet you that patient had the moderate aortic insufficiency or due to the root, replace the aortic
If
valve.
I can just make one comment, because it came up. We talked about mitral valve replacement having a higher mortality than mitral valve repair. The reason mitral valve replacement's higher is probably people listen to him and then go home and try it a couple of times. And across our whole nation, you throw them in the STS database and the mortality rate goes up. Tyrone, these are very complex things. If you don't have an, and you heard him now, 300 cases. He's been in practice 45 years doing mitral valve surgery. He found 2 per year, 3 per year to do?
10, 12 a year.
Okay, 10 a year. 10 a year. Read Carpentier's paper on sliding atrioplasty for mitral annular, calcification. It was, I think, 78 patients. I think your first publication was like 80 or 90 patients. These are tiny, tiny experiences. The average person will only see that to try that 2 or 3 times in their lifetime. Please learn how to do a replacement and respect the calcium. You'll save a lot more patients.
One last question from the audience.
Hi, my name is Matt. I'm one of the trainees at Western in London. I had a question with regards to mitral annular calcification. So in London, we occasionally use ultrasonic emulsification. And my observations have been, in some scenarios where you only need to decalcify one portion of the posterior annulus. To me, it seems like it's a little bit more controlled, a little bit more precise, rather than taking out an entire calcium bar. I know, Dr. David, you mentioned this morning that you're not a big fan of ultrasonic emulsification. I'm just hoping to hear your thoughts and any other thoughts from the panel.
So before I give this to Ahmed, I'll answer. So at the Cleveland Clinic at M&M, both Toby Cosgrove and Bruce Lytle would report, they'd have free wall ruptures when they did the resection, and also we did the ultrasonic calcification and all, and we actually had reasonably good results with it. I don't recall that they've written it up with that, but, in Cleveland, we were pretty conservative about doing the resection, and if you do it a lot, unless you do as many as Tyrone, you will have some free wall ruptures, most likely.
Right.
Ahmed, what did you guys
Yeah,
find?
so I think you're right, Don Carter. There has been a recent resurgence of this technology now. There is 2 products in the market, the Sonobet and the COSA. We have them. Actually, I had the video. I have to take it out for the sake of time, but you're right. You don't need to do extensive decalcification when you use the COSA. You just need to decalcify and remodel the annulus so it allows you to add sutures. So it makes the surgery a little bit more safe in that prospect. And if you decalcify the annulus, you don't need to reconstruct the annulus when you use the COSA because it really doesn't go deep into the ventricle, and just remodel the annulus so you can put sutures. So I mean, some centers, they told me it's a game changer for them to use the COSA. We included it in the AATS extra consensus document guidelines. But to be honest, I'm not sure if you really have to use it. I mean, there is a lot of other ways you can go around the MAC without needing to use a COSA device, but it's a good adjunctive tool. So at Mount Sinai, we have the device. In case we need it, we will use it, but it's not like a routine procedure for us.
Okay, well, thanks very much to all of the speakers. That was a great session, and we will move on with the case presentations now. Joanna, please stay here. Joe Wu